Noon. Good afternoon, everyone. I'm so pleased to welcome all of you today to a joint mental health briefing on the impact of COVID-19 on kids. My name is Adrienne Shilton, and I am a senior policy analyst with the California Alliance of Child and Family Services. We represent 150 community-based organizations serving children, youth, and families across the state in public human services systems. And we are so pleased to be partnering today with the California Children's Hospital Association. Each of our associations are joined today by leaders in the field. So our members will be talking about what they are seeing on the ground with examples from 6 children's hospitals. We will then transition to a panel about solutions, and both Alliance members and California Children's Hospital Association members will discuss our policy and budget proposals that we are putting forward this year to address the crisis in children's behavioral health. So thank you again so much for joining us. I wanted to go over just a couple of housekeeping items before we kick it off to Moises. So the first item is that this staff briefing is going to be recorded, so we can provide that recording to all of you following the briefing. We have a very packed agenda, so we're not going to do introductions at the start of all of the speakers, but you do have a full list of participants in your packet of materials. And if you did not receive those materials, you can contact either myself or Mira from the Children's Hospitals to get those. And also, please feel free to type in questions or comments in the chat box. We will be monitoring that throughout the session. And if we don't get to all of your questions, feel free to email both, again, myself or Mira from the Children's Hospitals. So with that, I'd like to kick this off by introducing the Alliance's board president, Moises Barón, who is also the CEO of the San Diego Center for Children. And he's going to be setting some additional context today about why we are gathered. So Moises, I will turn this over to you.
Thank you, Adrienne, very much, and good afternoon. We really appreciate the opportunity to be here to share some information and talk about some solutions. So wanted to provide some framework for today's conversation. I think that many of you know that even before the pandemic, we were already experiencing a mental health crisis in California, with more than 20% of our youth experiencing a mental, emotional, behavioral disorder. And as you will see from our colleagues in California's children's hospitals, the pandemic has made the situation significantly worse. Of concern is not only the number of youth that are struggling and the severity of the challenges that they're experiencing, but also the fact that many of them are not getting the help they need. Actually, when we look at some of the data, it shows that California ranks 34th in access to mental health care for youth. And when we talk about accessing services for depression, it's 45th, with more than 2/3 of our youth not getting the help they need. And the question is why? What are some of the factors that are contributing to that? Ideally, we would like to see an integrated continuum of services so that youth in need can access the help they need. And this continuum of services needs to incorporate prevention. We need to have collaborative care with mental health and primary care work together to be able to address, identify these needs. Outpatient health, in-home services like wraparound, mobile crisis response. We also need hospital diversion programs for those youth that experience more significant challenges like intensive outpatient programs or partial hospitalizations, residential treatment, inpatient for those youth with more acute problems, and of course, crisis stabilization and emergency department response. Ideally also, we should have pathways for these youth to be early identified and for them to be able to access together with their families the level of care and services they need. However, in California, we have what at times is a disconnected system of care with 3 different funding sources. Many of our youth, close to half of them, probably receive coverage through their families' health plans, commercial insurance, through the parents' work-related insurance. A lot of our youth also get access to care through managed care Medi-Cal and to the mental health plans, which are managed frequently by the county. But when we look at how these different continuum of service components are funded by this insurance, by these different funding sources, we can see that immediately there's some gaps, some very significant gaps. And that what is really of concern as well is that many of these gaps are impacting some of our most at risk and disadvantaged youth in the state. So it's not surprising then that youth that requires the access to care and by design may not be able to access some of these services, uh, we will experience some significant challenges and more significant crises. Another important component to consider is that a lot of these yeses that you see here are not necessarily green lights to access to care. Frequently, they're more like yellow lights because there's many inconsistencies that exist across counties and regions as it relates to eligibility, providability, and other factors. So today, given this framework and these concerns, we would like to talk about some solutions. But before we do that, we were going to be hearing from our colleagues in the Children's Hospital about what they're seeing and what they're experiencing as it relates to these challenges in their hospitals. So I'm going to stop sharing now, and Mira.
Unmute myself and stop my video. I'm on a roll. Good morning, everyone. Thank you, Moises, and thank you, Adrian, for the warm introduction to everyone. We're grateful to have you here today. We have a host of clinicians and children's mental health experts from our children's hospitals today, and I'm going to turn it over first to Dr. Bradley Peterson from CHLA to start with what they are seeing at CHLA on the ground.
So thank you all for being here today. It's a pleasure to be able to make a few comments. I wanted to let you know what we're experiencing in Los Angeles in our hospital. Since the start of the pandemic, Children's Hospital LA's overall inpatient census has been down about 30%, primarily because elective procedures and other things have been deferred. Despite the drop in the census, we've had an explosion in the number of children who've been hospitalized who require psychiatric services. And I would say that's up about 40% from our prior census. So it's probably close to about a 70 to 100% increase in the number of kids who are being seen for serious psychiatric problems. That increase derives primarily from a dramatic increase in the number and severity of suicide attempts in kids, as well as children who have eating disorders who are starving themselves. So very, very serious life-threatening conditions. These children can't be sent to acute psychiatric inpatient units because we have too few beds available in California. Moreover, those inpatient psychiatric beds that we do have are really in brief containment environments that prevent suicide in the short term, but where little to nothing happens therapeutically because the stays are too brief and frankly, the quality of care is generally suboptimal. Kids admitted to inpatient hospitals are discharged home within days with very little care put in place for discharge. At best, maybe once weekly psychotherapy, which is really inadequate for addressing serious suicidal ideation. What's needed for these children is access to intensive multidisciplinary care and a structured therapeutic environment. This is what residential treatment facilities provide and what acute inpatient units do not provide. The duration of stay in a residential facility is typically 30 days or so, give or take, which allows both medication therapy and psychotherapy to begin and their therapeutic effects to take hold. Just as important is that it allows a coherent treatment plan to be devised and put into place once the child returns home. So Bill AB 226, which you should have in front of you, will provide greater access to residential treatment facilities for these really severely ill and suicidal children, and it will save many young lives, and we urge you to support it. Thank you.
Great. Thank you, Dr. Peterson. And we will be kind of highlighting some of the bills that you should have received in your handouts. Again, if you didn't receive those in advance, please let us know. I'd like to move us a little bit towards the coast now and turn it over to Heather Husty from Chalk Children's in Orange County. Heather?
Thank you, Mira. We actually have been creating a system of care for pediatric mental health over the last couple of years. And I'll echo what Dr. Peterson was saying. is I think what we've seen with the pandemic is not only an increase in numbers, because we've definitely seen that, but an increase in acuity. And I'll give you a couple of data points just to help illustrate my point. We did open 2 years ago an inpatient mental health unit, and we'd be happy to talk to you more about that and some of the things we do there. What we have found is we have 18 beds. We've been full pretty much since April. There was a little lull right as the pandemic first hit, and then boom, we've been full ever since. The acuity rates are huge. The lengths of stay are longer. It's taking longer to stabilize children. We're seeing more psychotic disorders. So those are where kids are seeing things or hearing things other people aren't seeing or hearing. We also have struggled with the idea of kids who have psychiatric disorders and are suicidal and also are COVID positive. I think Dr. Peterson spoke to the lack of beds, triple, quadruple the lack of beds if a child's COVID positive. So we've also worked within our unit to safely care for children who are also COVID positive, which has been quite the lift, but we've been able to do it. I'll also mention to Dr. Peterson's point about IOP and residential level of care lacking for children who have Medi-Cal coverage. We see a 3 times greater readmit rate to our inpatient unit for children with Medi-Cal than children with commercial insurance, because we're able to discharge kids with commercial insurance into IOP, intensive outpatient, partial hospitalization, or residential care. And we're not able to do that with kids with Medi-Cal because those benefits are not paid for. In our emergency department, like everyone else's, we have a psychiatric team there. We've seen an increase in psychiatric crises, particularly July through September. We've had a doubling of the number who return within 30 days. And again, we believe that that's due to the acuity, the severity of their mental health illness, and the lack of resources, because everyone is overwhelmed in the community and it's hard to access resources, whether you have commercial insurance or Medi-Cal. We do have an intensive outpatient program that has been filled. We have tried to expand it as far as we can and modify it to fit in the COVID environment. What we've done, because we don't think it's fair that kids with Medi-Cal can't access those services, is we have contacted donors, and we've had some very generous donors who've supported children being able to access that program, and we've seen great success for those kids. We've also seen 122% increase in calls requesting therapy services. So people calling our department and saying, I need some help and support for my child. And again, it's very hard to access those resources and find those resources. And as everyone else, Dr. Peterson was mentioning, we've seen an increase in eating disorders. We have a specialized inpatient medical rescue. So kids with eating disorders are often medically unstable. We've seen a doubling in the census. We have 16 patients admitted today with eating disorders. And again, because we cannot send kids with Medi-Cal to an IOP, intensive outpatient level of care, we have twice the level of readmits for kids with Medi-Cal as kids who don't have Medi-Cal. We do see this as a fulminating crisis. And I'll just note, as I know all the rest of my panelists may agree with, the literature would suggest after a disaster of this proportion that these long-term psychological effects will last 3 to 5 years. It's not going to be over when the crisis is over. So I just want to emphasize why we're so fearful about this. Thank you for your time.
Thank you very much, Heather. And I would just add, one of the conversations that came up as we were prepping for this call and looking at the slide that Moises presented is you can see that there's a lot of boxes where there is technically coverage for a benefit, but what you're going to notice, you probably already started to notice, is that it doesn't necessarily exist in every county. It doesn't exist for every type of beneficiary. And so that's really a consistent theme. We don't have consistent coverage for much of anything in every county of the state for every child. And so that will be an ongoing problem, but we're trying to help kind of focus in on what we think the most critical needs are now. So next, I want to turn it over to Dr. Distelberg from Loma Linda University Children's Hospital in Inland Empire. Dr. Distelberg.
Thank you. Thank you for having me. Here at Loma Linda University Children's Hospital, we're located kind of on the border of San Bernardino and Riverside County. We're an 89-bed facility. About half of those beds are for youth and the other half are adult side of our hospital. It's a huge county, and what we struggled with pre-pandemic is geographically it's huge as well as census-wise. Pre-pandemic, we've always struggled with the boundaries of our service in providing care for patients that are in areas that really lack behavioral health care coverage, particularly the high desert area, Barstow, Victorville, and those areas of San Bernardino County. We have been lucky here to be able to provide almost the full continuum of behavioral health care for kids, everything from inpatient to partial hospitalization, intensive outpatient. And we recently opened up outpatient services. We don't offer residential care currently. That's a significant need in this community as well. We are also lucky that we've been able to partner with our local MCP, and that's the Inland Empire Health Plan, who does help support our kids with who are on Medi-Cal, who have the Medi-Cal IHP component. They are able to access our IOP and PHP services, and we're seeing huge benefits from that in terms of reduction of recidivism back into our inpatient arenas as well as ED. Currently, during the pandemic, I think I would just echo everything that every other hospital has said. And that pre-pandemic, we were very, very concerned about suicide self-injury rates as they've been going up roughly by about 7% every year since at least 2013. We don't have a good sense of what's happening with that in the pandemic world right now. We fear that it at least continue to go up, if not go up exponentially from pre-pandemic rates. Why we think that is true is because of what's been said already, is that our ED population is growing quickly and the intensity is growing. What we're struggling with here locally is trying to help kids get out of the ED and into the other levels of care as quickly as we can. But the lengths of stays are just getting way too long. There's no reason for a kid to be in an inpatient ED side of the inpatient side for more than 5 days. We're seeing well beyond that in most cases. And the reason for that is the bottleneck in the rest of the systems where there's nowhere else that can receive the kids in an appropriate way quick enough. We were lucky enough here to partner with our MCP and receive some funding from DHCS to pilot behavioral health integration activities. And that's significant for us because one of the other populations that's getting overlooked in the pandemic is kids that have physical health issues with also behavioral health components to that. We launched some programs here that have been very successful and shown cost benefit analysis to them. But those kids we don't know where they are right now. They used to be connected with schools and other services that are online right now, and they're not showing up in the rate that they used to be. So we're fearful that they're out there and they're struggling and not getting connected in. And that's in addition to the population that is showing up in the ED, which is the self-injury. Those cases are just flooding the EDs right now, and we're struggling to figure out how do we get them out of there into appropriate levels of care. Because it's what's been said before, the ED is really a great place to protect a kid, but not change the situation. And if nothing happens after that, they're just very likely just to show back up there again. Thank you.
Great, thank you, Dr. Distelberg. And I know we'll be talking about this a little bit more, but I think what he started to allude to is that there is fear that there is really this wave coming of all the kids we don't see, right? All the kids who aren't showing up in an ER are also struggling, but they don't have anywhere to present to right now. They're not showing up in primary care provider offices. They're not showing up in schools. And as a result, there's just this giant wave of need that we haven't even seen yet. And some of the solutions we will talk about later are really designed to address that wave that we think is coming and that will likely last for well beyond 2022. So with that, I'd like to turn it over to Dr. Stephen Adelsheim with Lucille Packard Children's Hospital in the Bay Area.
Thanks so much. And it's great to be able to be with everybody. And I think to the point, Mary, you just made, I think, given what we're hearing from everyone about the issues related to the need for more inpatient care, better emergency room support, and all the other needs workforce-wise, I think what I would focus on as our director of our Center for Youth Mental Health and Wellbeing and our role with community engagement is some of the other issues that are also coming up related to where are all these other young people and what are the other experiences. We've really been trying to focus on building out some of the early intervention support as well. And what we're also really seeing, in addition to all these additional needs in terms of hospitalization and high levels of care, is many isolated young people who are still grieving the loss of their friends, critical social activities, feeling challenged being at home, and families seeking wherever they can find support and guidance on how to be able to reach out to their young people in more effective ways. We have been involved in some telehealth partnerships with some of our rural partners in isolated areas who are continuing to struggle with the ability to even make connectivity to the internet or do virtual care, and see huge needs to still be able to build out those outpatient linkages in simple ways. People have shared the issues related to the higher rates of referrals for depression and anxiety, and our longer waiting lists. Our young people are being actually sought out to present to other young people and help them how to give support. We had our virtual youth community town hall on COVID last week, with 300 families reaching out and asking some of our youth about how to handle situations at home, how to deal with social media in safe ways, and how to build additional kinds of support when young people aren't able to connect in school. We're getting many more requests for school mental health consultation from schools in our area as well as across the state. And related to that, as people have spoken about the suicide prevention issues as well, many more requests for guidance from schools, from emergency rooms, from hospitals, and family groups about how to recognize some of these issues within families, within schools, and strategies for addressing critical and crisis response around suicide risk as well. We've been working to develop integrated youth mental health sites, and now we have many communities reaching out to us asking, how do we develop these early intervention models as well? So I would just add those to in terms of the front end of the continuum of care, where there's also just a huge need. Thank you.
Thank you very much, Steve. Next, I will be turning it over to our team we were fortunate to get quite a few folks from Rady Children's Hospital today, and I don't know which of you is starting. Looks like maybe you, Ben.
Yeah, I'll start. Well, we're just going to go through a few slides just for the visual learners out there, but we're seeing many of the same things that have been mentioned by the other people on the call, and certainly everyone's seen these headlines over the past several months of the concern that the social implications, social isolations related to COVID restrictions are really worsening the child psychiatry crisis we were seeing even before. We've seen this national data has looked at loneliness, hopelessness, 911 calls, ED visits. This has been seen nationwide that there's a crisis that's brewing because of COVID-19 and kids' mental health. But we shouldn't pretend that this started with COVID. You know, we were in a crisis before all of this. This is our percentage increase over the last 10 years or so in ED visits. So for context, we saw the same number of psychiatric patients in the Rady Children's ED in 2 weeks that we saw in the entire year of 2011. So this has been an increase we've been seeing really for the past decade, and COVID has made that worse. Now, it's not to highlight this to say we need only more inpatient beds or more ED services. Far too common, the phrase we hear in our emergency department with our clinicians is, if only we had this patient see a therapist a year ago, if only there was a residential we could send this kid to, if only there was an intensive outpatient program. So far too common, these kids arriving in our emergency departments represent failures of the behavioral health system. There's many obstacles we face on a daily basis. Some of these have been mentioned already. In our outpatient clinics, approximately 50% of our clinicians' time is spent with documentation. So we have longer and longer wait lists because our clinicians are more and more bogged down with documentation requirements. Many times our clinicians get dissatisfied with that type of care and end up having a retention problem where our clinicians are going into private practice. And so ultimately a lot of our clinicians are trainees or new graduates, and the more experienced people are going elsewhere. And as has been touched on previously, the lack of a complete continuum of care really causes us a lot of difficulties. So on our inpatient unit, kids can't be discharged because there's not a residential to send them to or an IOP to send them to. Same in our emergency department. So what happens is the whole system gets bogged down. Kids start stacking up in the emergency departments around the area. And many times kids are discharged from the emergency departments without a care plan that we would all feel happy with. And it's because the alternative, they sit in an emergency department for a week. And most of the clinicians and families just can't stomach that. So we see a lot of these obstacles that have been mentioned previously. And just to end, this is all, one of the main things we're concerned about is suicide prevention. So suicide is the second leading cause of death in young people, teens. Here at Rady Children's Hospital, we've done over 300,000 depression screens over the past 4 years. The results of that is many kids are coming back with depression when they're coming in for an appointment visit of some other type. And we've found 11,000 screens over that time that were high risk for suicide. Kids thinking about suicide, kids having attempted suicide recently and not told anybody. So it's this ultimate concern of how do we prevent the tragedy of teen suicide, and how do we create a system of care that can get kids the care they need when they need it. And I will stop sharing there.
All right, Brent or Sandra?
Just to highlight what Dr. Maxwell was saying, as well as RED, as you can see, have been inundated with a number high level volume. But in that volume is we're seeing more and more complex kids. Parents are so at an end or at wit's end as to what to do. The children are so dysregulated that what they're coming in for is, what do I do? And without residential treatment and more residential treatment, they're diverting to the child welfare system and relinquishing their kids to care. And that isn't treatment. That's just a temporary holding tank for a child to stay in until the family can kind of get reassembled and back to maybe considering a reunification with their child. So we're not treating the problem, we're just shifting into another system of care that isn't always the most effective. So what we really want to highlight is a high need for the residential facilities. And in addition to that, we call it here a cliff of care. We've got a high level acute support that we rush in and stabilize children, and then we send them, as many of my colleagues have described today, to the outpatient arena. But without intensive outpatient services, we are essentially pushing kids off a cliff back to the community with not a lot of stabilization and treatment. So we self-perpetuate and systemically perpetuate our own problem with the limited resources that we're describing.
Thank you. Brent? Dr. Grant?
Thank you. I think it's covered, and because of time, I'll just let you move on.
Okay. Thank you, everyone. I have to get you unpinned, so give me a moment. It's the technology side of this. All right, and our last, but not least, presenter is going to be Dr. King from UCSF Benioff Children's Hospitals in San Francisco and Oakland. And I'm trying to find you.
Maybe it'll help if I start talking. I'll
Yes,
get a yellow.
I've got you now.
Thanks, Miriam. Thank you, everyone. I so appreciate the opportunity to join you today. And I think really the folks who have preceded me here have made the important points. Just to amplify some of those, as was just said and has been said by virtually all of us, there was a pandemic that that existed before COVID. And that pandemic, by every measure and criterion, extended throughout the world and involved children's mental health. We heard a moment ago that suicide is the leading cause of death in young people. And that has been true since 2013. And not only is it the leading cause of death, but it's greater than the sum total of deaths from cancer and heart disease and AIDS and birth defects, stroke, pneumonia, influenza, and chronic lung disease combined. Suicide is, a house on fire here, and it's been for over a decade. And among the things that we've heard that contributes to this are the gaps in the system of care that we experience in trying to address these needs, and also our inability to get people in where there might be a place. At San Francisco and Oakland Benioff Children's Hospitals, we have a very large footprint in terms of outpatient care. We saw over 55,000 outpatient visits between Oakland and San Francisco last year. And when COVID hit, our outpatient volumes increased dramatically as we shifted to entirely a telehealth platform, up by nearly 60% in some of our clinics. And sadly, the waiting lists across the board all just got longer. And so we're looking for ways that we can leverage what we have more effectively to get out in front, and also to address gaps in the system of care. We're lacking in inpatient beds in the Bay Area, and particularly for the kinds of kids that you heard about earlier who may have co-occurring medical and psychiatric conditions. We're looking to move into and expand our presence in schools and communities to build out condition-specific care. And one of the programs that we've stood up in the last year has been a teleconsultation program to primary care physicians. So with some philanthropic support and successful recruiting, we have a child and adolescent psychiatry portal that essentially provides real-time direct consultation to primary care physicians in the Bay Area. We've enrolled 71 pediatric practices so far that represent over 250,000 pediatric lives. The volumes in the call center have increased steadily over time. But we're excited about the prospect of expanding that. And just last week, in partnership with Anthem, have a go-ahead to expand the access into the Central Valley, where we'll be taking on another 250,000 lives before long. We see this as a great opportunity to support our colleagues in primary care to identify and move forward treatment for mental health. Lastly, I would just say that, again, the volumes that you heard reflected in terms of kids coming in through the emergency departments and so on clearly are reflected here. But one of the things that's happening in the press in the Bay Area, at least, is a perception that all we have to do is open schools again, and the pandemic will be in the rearview mirror. And in fact, as you've heard, nothing could be farther from the truth. Every year, year over year, we see an actual increase in the demand for psychiatric services when school reopens in the fall. And this year, we're going to have kids coming to school who have been, turning off their screen on demand, or getting up and walking around, kids with attention deficit disorder who have to wear a mask and stay 6 feet away from everybody in class. We're really concerned about what we're facing in terms of the need, and really want to get out in front of that. Thank you again for the opportunity to share. I think sometimes hearing all of this can't help but be reminded of the saying that the ocean is so large and our boat feels so small. But anything we can do to get a larger boat is going to be really helpful.
Thanks very much, Brian, and everybody who has presented. And I know we really just wanted to paint a picture for all of you. A lot of you know kind of anecdotally, or you see news stories about what's happening out there and that kids are struggling. But I think as we talk to our clinical folks, we really get a sense of just how severe it is and what may actually be coming. But we don't want to leave you just with the problem. We also want to provide you with what we think the legislature and lawmakers can be working on to try to address this. And so I'm going to turn it back over to Moises, who is going to lead the conversation about potential solutions that we are going to be advocating for both organizations this year. So Moises?
Thank you, Mira. So as you've heard, the problems are significant and they're getting worse. And I think that there's little question that this is happening statewide and probably nationwide. To be able to really have an impact and make a change, we need to have a dedicated and planful effort to remove roadblocks. And we may not be able to do it all at once, but we need to really work to turn all these no's into yeses and all these yellow yeses to green yeses, so that really we have youth that have the appropriate efforts to be able to identify the problems and connect them with the appropriate level of care, regardless of who is funding their care. And that's something that's very important. But we have an opportunity this year to start making a dent. And I wanted just to highlight what those proposed solutions are, where they fit in this continuum, and you're going to be hearing from my colleagues as they describe more in depth what these solutions are. So first, you're going to be hearing from Seneca Family of Services talking about SB 293. You heard before that our clinicians are spending on the specialty mental health side more than 50% of their time doing paperwork, while there is a tremendous need for help. So this is a bill that potentially can help address that and provide solutions to that issue. We also heard about the concerns that exist in terms of identifying appropriate supports for youth who are being discharged from the hospital or for emergency departments, and the creation of children's crisis residential is something that is badly needed to be able to give access to this level of care to youth with Medi-Cal. So you're going to be hearing from my colleagues in Casa Pacifica that are going to be talking about how this bill from Assemblymember Ramos can really help address this issue. And you're going to be also hearing about an exciting project that is being proposed by the Children's Hospital Association to create a grant program, a competitive grant program to educate and support primary care and school professionals in identifying and responding to youth with mental health needs. And last but not least, you're going to be hearing also from Casa Pacifica about the need we have to be able to provide the appropriate funds to be able to create an integrated evidence-based approach to address the suicide crisis that we're experiencing with our youth. So I'm going to hand it over to Ken from Seneca, and then we'll go through the different solutions.
Thanks, Moises. I appreciate it. And I so appreciate the opportunity to talk to you all today about problems that have real solutions, about things that we can do. You know, and I can say what my colleagues from Children's Hospital can't say, which is California has this gem of constellation of children's hospitals, the envy of every state in the union, this incredible resource. And we get to work with Children's Hospital from Orange County, with CHOC and Children's Hospital of Oakland for many years, and know very directly the things that we could do in partnership with them. And this coming together is symbolic of that potential partnership by working with the state to create a real continuum. It's just painful to hear Dr. Maxwell talk about the if only. If only we had a step-down service that should be standard. If only we were able to address these needs in a seamless way, which we should be able to do easily. And if only, and this is the most painful one, if only we didn't burden our staff with 30 to 40% of their time spent on paperwork that is absolutely unnecessary and provides no clinical benefit at all. and is also unnecessary relative to the requirements of the federal government, which have much easier audit standards. Seneca is one of the few organizations that works across states. And so we're able to see that these documentation standards are not necessary. They're burdensome. And I get to be the good news guy here, because some of these solutions really do cost money and will take time and effort and energy and focus. They're worth it, the continuum of care solutions. This is a solution that costs nothing. All it takes is our collective will to say, what are the requirements of the federal government? How do we provide for best clinical practice? And how do we free up a resource that brings 30%, 40% more attention to kids and families across the state? We can do it, and we can do it right now. And we have examples of how we can do it. And I'm going to turn this over to Letitia Gallion to talk about both the detail of the problem and some of the solutions that we think we can put forward in partnership with you all.
Hi, everyone. Thank you for having us today and devoting time to hearing what these solutions can be. As you heard from our hospital partners, certainly there is a need out there. And really one of the easiest things that we can do to create the opportunity for more services, for more access, is to reduce unnecessary administrative and documentation burdens for our staff. So you heard Ken talk about the fact that this is a need. That when I say that this is a problem and a need, what I mean is that what's currently happening is that 58 counties have the opportunity to interpret in their own ways what it is the federal requirements are, and then create unique requirements in order to be able to do the documentation, who can approve the documentation, who can write the documentation, how you submit that documentation, and then how you get paid for that documentation. And truly, each county does that differently. What that means is that we've had to build an intensive infrastructure in order to actually be able to generate that revenue and to pull that down. That comes at a cost of at least 15% of the revenue that we're generating. If we didn't have to have that infrastructure, that would be resources going to additional services for kids and families. And you've heard folks talk about the impact to our staff. When one of our supervisors asked our staff, what is the single most important thing I could do today to improve your experience at work? It wasn't about the safety for them. It wasn't about the intensity of the kids that they're serving. It was about changing the paperwork burden that they have. And that is something that we can do. But as a provider, we're beholden to the requirements that each of our county partners has. And we're an entity that partners with 15 different counties. So we have 15 different requirements. The burden exists even for those who have contracts with just one county. For example, one of our county partners was implementing a new form to just change a DSM-5 diagnosis for a client and family. Our clinicians happened to get out ahead of that and submitted that document one day early. Because the county hadn't implemented that yet, we were disallowed for $37,000 in services that were provided. We were able to appeal and get that back, but that required incredible resources in order to do that. This has to look different, and it can. AB 293 will start to get us in that direction because it can help create that uniformed way in which we can define by the CMS standards, by the federal regulations, what is necessary and only what is necessary. On top of that, providers can certainly then do the kinds of documentation and additions that they would want to make it clinically meaningful, but that requirement isn't necessary in order to bill for those services to generate that revenue. So I appreciate your consideration.
Next, we're going to turn this over to Shauna Morris, who is the CEO of Casa Pacifica, to talk about the need for a children's crisis residential program.
Great. Thank you. Happy Friday. Thank you for taking time today. My gosh, as I sit here and I listen to our partners that struggle every day finding places for these youth that are in your emergency department, I don't want to just pile on, but I do want to pile on a little bit because this is what we deal with every day. So thank you so much for your time today, and thank you for listening to us. So we, at Casa Pacifica, we work closely with Marion Regional Medical Center. And recently we asked one of the emergency physicians, how's it going? How are we doing with moving kids along? And what he said to us was heartbreaking. And earlier, your physicians here have put some voice to this, but I'm going to give you just a couple real life examples of what happens. And then, like my other colleagues, I'm going to give you some solutions that we would like very much to have your support for. So let me read to you about a 9-year-old female was on hold for suicidal, trying to kill herself. And we repeatedly called our crisis team. And we brought her to the emergency, her parents brought her to the emergency room. And there was no bed available for her. No bed available anywhere. And so finally on the 3rd day, the ER found her a bed in San Francisco, which was only an 8-hour drive away. She was on a hold and put her into an ambulance by herself because her parents could not afford to make that 8-hour drive. Unfortunately, in the middle of that drive, her legal hold expired. And so now the ambulance was in a tough spot because they had a 9-year-old female who was no longer under a legal hold and didn't know what to do. So they took her to where she was supposed to be. And they called the family and said, you need to come and pick her up again because she's no longer on a legal hold. They drove to San Francisco. The whole process restarted. The family called for support. And we ended up giving the parents an attorney in the county so that they could file a lawsuit to try to figure out how to make so their 9-year-old child could get what she needed. We never heard from the parents again. They took the child and left. That's just one story, and I can tell you many, many more, but that's really not what my job here is today. I just wanted to put some real life story in front of you. What I am happy to tell you is that there is a solution for this. We'd like your support for AB 226 because it basically changes or it clarifies some of the licensure issues that we're struggling with. And by clarifying these licensing issues, it allows the counties to draw down federal dollars to make so that we can have crisis residential programs available within each county, so that there's no reason that a 9-year-old should be ever put in an ambulance and driven for 8 hours to San Francisco to have the parents go pick them up and bring them back. So this is it's an easy fix. We think it's an easy fix because it's a rule change. It doesn't cost us any more. It actually allows for dollars to come into California, which is super important for us these days. And it was an oversight when this first was put into place. It was one of those unintentional oversights that we weren't quite as thorough as we might have been. And so our request to you today is to support us in making sure that we get this legislative fix. All right, Marika, you want to talk about our other project today?
Yes, good morning, everyone. Thank you so much for your time. I also want to just thank you in advance or retrospectively for actually approving the legislation last year that created the Office of Suicide Prevention. So I feel like I'm preaching to the choir in terms of the need for this funding for this critical office. You've heard the vignettes, you've heard the stories, we're all familiar with just how prevalent death by suicide is among our youngsters. I would say, since this office is addressing the issue of suicide across the lifespan, it is important to point out that unlike other causes of death, death by suicide really does, it's prevalent throughout the lifespan. Obviously very prevalent among our youth between the ages of 10 and 24. And then again, it really spikes throughout the lifespan, but then again, over the ages of 85. You know, the other issue we've touched upon in light of COVID and just youth and adolescent development, as Dr. Adelsheim touched upon, we really need to focus on prevention efforts. And I was happy to read a report that was put out by the California Department of Public Health that talks about, you know, a very simple 4-step approach to prevention efforts, 3 of which we've pretty much nailed in terms of defining the problem, identifying the risks, and identifying prevention strategies. But the final key piece to kind of bringing it all together is making sure that there's a widespread a mechanism for disseminating that information, that critical information, to the folks in the field working with these kids in the schools, in their communities, in residential programs. There's just so much information and so much science there, and so much great work like they're doing out in these hospitals that you're hearing from today. We really just need to fund this really critical effort so we can do the work and save these precious lives, because they're our future. These are our future leaders, and we really need to put the money into those prevention efforts more than anything. Thank you very much for your time.
Thank you, Marika. We're going to move to the final presenter on this panel on solutions, Dr. Steve Adelsheim, to talk about the California Children's Hospital sponsored bill and budget item about Project ECHO mental health grants. Dr. Adelsheim.
Thanks, Adrienne, and thank you again. I know our time is short, so what I want to quickly share with you really follows up on the wonderful work Dr. King has shared about the work being done at UCSF in building out collaborations with primary care providers to provide their immediate support. The Project ECHO model is a model that started in New Mexico that's now really seen as an internationally known, cost-effective, evidence-based model for providing critical support for providers and specialists all over a large community to get the early support they need to increase their capacity to support young people with multiple issues. The goal of AB 64 is to create this model here in California and support our children's hospitals in being the home bases and hubs to support school programs, primary care providers across the state to be able to get early intervention support and consultation as they're seeing young people returning to their schools and coming out of their homes with these mental health needs we've been talking about. This model allows for immediate case consultation via televideo, where the providers in more distal areas explain the concerns they have about the young people that they're seeing. And with a multidisciplinary team of behavioral health experts from our systems and supports, we're able to help those providers feel more confident and comfortable meeting the needs of the young people and families that they're seeing in their home communities. So while we're providing support and consultation, we're also improving the capacity of our workforce that works with our young people to be able to manage young people as they're dealing with more complex issues and more complicated types of situations. As we said earlier, we've had these needs for this type of support before COVID, and now, as we've been discussing today, the need is even that much greater. So our hope is that we can be building out these sites through our children's hospitals to link to schools, primary care provider settings, and other community settings to build the support for our young people and families through consultation and helping our workforce become more comfortable. This is an important time to do this. It's something we can readily and quickly expand on without taking a huge amount of time to get it up and running. So this seems like a critical moment and a worthy investment for our children's future at this really critical time. Thanks.
Great, thank you, Steve, and everyone on this panel. I think we have a hard stop because we have another briefing with some of your bosses, the Senate Mental Health Caucus at 1, but I do think we have time for 1 or 2 questions if there are folks out there who have them. I also have any questions? If so, you can raise your hand, you can type it in the Q&A box, or you can put it in the chat.
Mira, while folks are thinking about that, I did want to read one of the questions in the chat and maybe give Dr. Adelsheim just an opportunity for a brief response, which is that he mentioned an integrated mental health program that you've developed called Project Alcove. I know you put some information in the chat, Dr. Adelsheim, but any other comments you wanted to make for the full attendees here about Project Alcove?
Well, thanks very much. What I would just quickly say is, we've seen really the importance of building a public mental health continuum of care, from school health and mental health to these integrated youth mental health models to the early psychosis related issues early psychosis, and being able to have a place for young people to comfortably come in early and get the care that they would like to have. We keep talking about half of all mental health conditions starting by the age of 14, but we really don't have easy access points for young people to come in and get the care when they actually want it themselves very much of the time. So in partnership with the Oversight Commission and with other partners in Santa Clara County, we're starting these integrated youth mental health models that have early mental health care, primary care, support education, employment, early addiction treatment, and peer support as places that are also guided by the voice of young people to come in for ages 12 to 25 for early mental health support. We're starting the first 2 in Santa Clara County this spring and are partnering on the rollout of 5 other ones in a pilot phase across the state. So thanks for this opportunity. We see, as everyone's talking about, the need for early support for young people and a place that feels comfortable for them. And we're grateful to have the chance to start building this model out.
Eve and Adrian, we did have one other question that I want to throw out to the group. Somebody asking, is there any other low-hanging fruit on prevention, your if-onlys on prevention and early intervention that you'd like to suggest in our last few minutes? I think, Heather, you had one, and then we'll open it up to other folks. Oh, you're muted.
I want to go a whole day where I don't mess up the unmute and have not yet achieved it. I do think one of the things we've experienced is the lack of Medi-Cal paying for mental health related IOP. And that also would be a rule change. So and I do know that Dr. Pfeiffer is working on that, but I think that support to open that up so that all children can get that level of service would be super helpful.
Great. Yeah, Ken?
Yeah, I think there is some low-hanging fruit, and I think particularly as the hospitals have talked about transitions, and as youth are coming back from being out of COVID, we're going to see more crisis, and we can deal with that by using inpatient resources, or we could take the model that's been set by the urgent response system for foster care and do what San Francisco has done, which is expand it to make it more broadly available so that we can, at one hand, divert kids from being hospitalized. And at the other hand, the children's hospitals would have a number to say, if your child's in crisis, you can deal with that crisis with a mobile response team that can support you without necessarily having to bring your child into the hospital. Those transition services, both at the front end and the back end, can be really critical and are going to be even more critical in supporting schools and parents and communities as youth come back and make the transition from being isolated under COVID.
Do we have time for one more?
Yeah.
I just wanted to mention, we've been talking about early identification. Yes, schools play an important role in this effort, but I think that focusing on collaborative care is really important and how to be able to support that. We have a partnership with Radies in San Diego to be able to do this, and we're finding that it can be very effective as we train primary care to be able to identify these challenges and have mental health providers working alongside to be able to really properly identify the level of need and care that it's needed and give you the quick access to the full continuum of care. So that's an important solution also that we need to think about and consider.
Great, thank you. And thank you. I want to thank everybody who joined for this briefing today. We're really, really appreciative of you taking the time to learn more about this important issue. We encourage you to reach out if you have questions, if you want to follow up on any of the points we've raised today. And I also want to thank all of our panelists who joined us today to do this. I know we have a couple more, but this is really valuable time that you're taking, and we just really appreciate that. And thank you, Adrian, for being such an able facilitator while I tried to manage the technology. So we will be sending out a recording of this call to all of you, and happy to follow up on any questions you may have. But now we will give you back your day. All right, thank you, everyone. Bye.